Good morning. It is really an honor to be here with all of you today. I come from a rather large healthcare system in rural Pennsylvania, and I was excited to be offered this opportunity to come and talk today, but I was really panicky because the idea here was to figure out how to financially sustain these programs. And the truth is, if I knew this, I would have a solid 10 or 15 more social workers doing this work with me. So I'm really excited to share with you about how our integrated care system works, how it works to benefit our patients, how I get to be a part of that. But I'm also really excited to be here and hear what kind of data you're all collecting, because it has given me an opportunity to speak more with my administrators about what do I need to do to sustain this more, to bring on more folks, to take care of more people. So I just wanted to give you a bit of a glance of what Geisinger looks like. So Geisinger is a large integrated healthcare system that has both a medical center arm and a healthcare arm, and also a health insurer. We are Geisinger Health Plan as well. We are large. There are 9 hospitals covering 45 of the 67 counties in Pennsylvania, and we've now recently moved into the New Jersey population a bit. Something interesting about our healthcare system is we also have 50 primary care offices, which is beneficial to us and our patient population for many reasons I'll be glad to share with you. So we have around 30,000 employees. It's a big and rural system. But specifically, we have this large system of hematology and oncology and also radiation oncology centers. So we are spread out across the entirety of a large portion of the state. And so here are our actual hospital systems, and more importantly, this kind of overview of where all of our primary care offices, specialty care offices are across the state of Pennsylvania. So again, Geisinger Health Plan. So when I kind of think about this and the way that I talk about this in the work that I do is we've got this giant name of Geisinger and then 2 full arms of what's going on. We've got a healthcare system that is not for profit and taking care of folks regardless of their ability to pay for things. And then we have this health plan thing that really ultimately drives where our money comes from. And as a social worker, I've got this real challenging structure standing right in the middle of those 2 things. Because I don't like to think about patients in the way of numbers. And I'm grateful you're all collecting this data, but it's not how I see people. I see people as the sick person walking through the door. And so when the health plan tells me that I've got to look at things, and keep people out of the hospital when I see a sick person and say, oh, I really want them to get to the ER. But wait, hold on. The health plan says they've got to stay out of the ER. It's really incredibly challenging. The benefit, however, here has been an incredible benefit for me, is that Geisinger Health Plan has a long-standing history of this really awesome program called the Proven Navigator services. So they have RN case managers, 120 of them, which is pretty incredible. They're seated and embedded in our community practice sites. And recently, in the last year, they have also added 26 community health assistants. So also known in our world as community health workers, but by the health plan assistants, they are calling them CHAs. Odd name to me, but it's working. And these community health assistants are doing exactly the same kind of work in not necessarily cancer patients, but it is beneficial to our cancer patients. So I say this to you. So here's just a fair overview. I wanted you to know what these folks are doing. They're doing great work. They're collecting tons of data. But I wanted you to understand why they're beneficial to me. So this is how we started. And our system is so large that when we came on board in oncology specific, we were awarded this NCI Community Cancer Centers Program grant. I know there's some folks in the room who remember this grant. And so at the time, the health plan already had those case managers and everything was working from that perspective. But from an oncology perspective, we didn't have any support services at all in all of oncology. It seems crazy because Geisinger is really this leader in things. But it was an opportunity for Geisinger to hire some navigators. We heard a little yesterday about that idea of don't hire navigators to fix a problem you're not sure you want to fix. Well, that's what happened. So ultimately, there were 4 RN nurse navigators hired for this program, and they were thrown into the Wild West. They weren't exactly sure what their role was going to be. They weren't sure what their intentions were. And they were sort of said, let's send you out into primary care. We've got all these great sites in primary care. Let's send you out there with those already pre-standing health plan nurse navigators and see if you can find these suspicious finding folks. Let's see if you can find these people before they even make it to the biopsy and see if you can start navigating them from that perspective. So the trouble, of course, was that they were having a really hard time because, as you know, and I'll tell you, if there's anything you take away from all that I talk with you about today, is that you really have to have buy-in from the people that you work with. As a social worker, as a nurse navigator, as a community health worker, if your team does not believe in the work that you're doing, frankly, if you don't believe in the work that you're doing, it's going to be very hard to get anything done. So what was happening is these nurse navigators were thrown into primary care and didn't really understand that they needed to make these relationships with all of the physicians, which could be large practices of 5 or 6 physicians. So they were having a bit of a hard time getting these new referrals. They were having a hard time. So I just wanted to note, though, during that time, for reporting purposes, we were collecting our data via SharePoint. We were also documenting in the electronic medical record at that time. So in 2012, one of our nurse navigators was departing. He wanted to go back to bedside nursing. It was fair. He was struggling. He wasn't exactly sure what his role was. He was doing a lot of interesting things. I heard he was cooking in the community for folks to talk about healthy food, but he was struggling. He was taking blood pressures, and then the primary care nurses were slapping his hand and saying, "No, that's not your job. What are you doing?" So when he was leaving, he said, I think you guys are doing something great here, but oh gosh, these folks need far more than what I'm prepared to do. So in comes me, the social worker. He says, these folks these are, again, rural Pennsylvania. We're very much Appalachia. He said, these folks really need help in understanding how to access medical assistance. This was really a time when people had no insurance. These are folks who needed assistance in getting Social Security disability. They were needing referrals to places, and he had no idea how or where to refer these folks to. So when he left, I came on board. So with my addition, I was just taking a look at what was happening with my nurse counterparts, who really were a fantastic team of people and working hard to create something that they weren't sure what they were working on creating. So I loved being in primary care. I worked hard in that buy-in, but I realized really quickly, if you want me to work with folks who have cancer, this is not the place. So I just suggested we need to get out of primary care, and I know our intention was to meet these folks early, but get out of primary care and go to the cancer centers. There was no support services in the cancer centers. So we did that. We all sort of left our way. The 4 of us moved into a cancer center, interspersed across the state of Pennsylvania. And in about 2013, we made this plan that all new patients would be directly referred to us, and that came through Epic. We were doing direct referrals. And then I started trying to get us a little bit on board with, can we document the same way at least? So can we at least say, what we've done, what happened here, and what's the plan moving forward? Can we get on some sort of semblance of documentation so that if someone sees what we're doing, they're seeing what we're all doing? So this was just some of the statistics in those four navigators. And you can see there, right about the time when we were taking all new patient referrals. It really spiked up at that time. So where we are now is we currently have 8 total oncology navigators. 5 of us are social workers, 3 of us are nurses. We cover 7 of the 11 medical and radiation oncology sites in Pennsylvania for Geisinger. And right now, we're not really doing any direct data collection, although you guys have inspired me. I'm definitely not a numbers person, I'm totally a doer, but you've really inspired me. But what data I could grab while I was putting together this presentation was how many touches did we all have? And so if you remember back here, we were somewhere in the 3,344 range for 4 navigators. And that was, for a long period of time. That was for 4 years. And then I want you to, I've gone the wrong way. I want you to see then that in 6 months, I'm really proud to say that we've had nearly 6,000 touches. So it really goes to show that when you get these folks into places where they can be useful, that these touches matter. Now, one of the things I'm looking forward to in 2018 that we're going to start collecting is how much time we're spending on those touches. You know, just last week I had a patient who's really complex, and I spent a solid 4 or 5 hours with him. But I kept him out of an inpatient stay. I got him associated with palliative medicine a second time. That was 4 hours. And so one touch does not really do justice to the significance of time that we're currently spending with people. So I heard someone say, Nick, was it you that said a crack filler? I say that all the time. I fill in the gaps for people. They say, well, what do you do? I say, I do all the things that are in the middle. All the things that you're not sure you need, that's me. I'm glad to do all of those things. And that's a lot of things, I'm not gonna lie. I've taken a real hard stand on transportation. In Pennsylvania, we don't have a really fantastic transportation scenario. So I'm working a bit with the Department of Health. I'm working with some local community resources. I'm working hard with Geisinger to help them understand the need for transportation. We're about to start doing some data collection associated with missed appointments because of transportation. I mean, right now it's really a challenge. But I do all sorts of things, including insurance, which is just, I mean, I'm sorry, Wendy, but really, whew, what a challenge insurance is. None are the same. Forget getting a pre-cert, and then you see you've got a $7,000 out of pocket, and this is a poor Medicare person, and how am I gonna help them pay that bill? They're panicking, they're freaking out, they're questioning whether they should even move forward with treatment. So this is more than knowing insurance. This is really about helping folks find the comfort and understanding that we'll get you there, we'll help you figure this out. Some of the best, most privileged work I get to do is end-of-life issues. I said earlier today, I don't think it's hard to see that I really love what I do, but there's a real privilege in being present with someone when they're experiencing something so significant, and that's definitely the privilege of my life. So I also want to say that in our clinics, we have really great nurses. So, you know, we're not missing nurses. We identify our nurses who are associated with physicians as our specialty nurses. They're taking care of all the day-to-day things. They're taking care of our chemo teaching, our chemo scheduling, our prescription refills, those sorts of things. So for a very long time when I started, I wanted to document. There is a massive invisible line, and it took me a really long time to figure out where I couldn't cross. And there was a lot of challenge with that. But boy, oh boy, once I finally gained that buy-in, how beneficial we were to each other. Nurses and social workers really do take over the world together. But you've got to figure out what, is that not right? But you've got to figure out where can I as a social worker get to, and where must the nurse take over? And where can we sort of be gray in the middle because we've got to take care of this patient. So I also wanted to say, though, that I'm giving you a brief look at oncology, but really in Geisinger as a system, we have 60 navigators. So these are the people that a lot of you folks are talking about. They are capturing people really early. They're working in surgery. They're working in some specialty clinics, identifying, you know, early issues, getting these folks to biopsy, getting them, you know, their mammograms, their colonoscopies. They are all and mostly funded within their own departments. So we are not like a large navigation system. And interestingly, something you said, Cindy, I thought, boy, maybe I should send a survey out to all those people. Maybe we should look at what's going on with all those folks. So a lot of really great opportunities I'm learning about today. There are also a handful of lay navigators or patient navigators who are, you know, I really think you can teach this stuff. There's a certain amount you've got to come with. You've got to have some gusto, some willingness, some ability to, you know, step outside boxes and think bigger than you're prepared to. But I really do think that you can teach this to folks, and I'm looking forward to that being something that I can create within Geisinger soon. So I just wanted to make some mentions about things that we have learned. If anything you take from me, you have to have buy-in. No one can be successful in a medical team without buy-in, and it's hard. We recently added a navigator at our main hub at Napper Clinic, and I said to her, please, whatever you do, she's a social worker, fantastic social worker, tons of experience. Whatever you do, please don't see a patient for 6 months. Please spend 6 months making the infusion nurses talk with the specialty nurses and meeting all the physicians and making sure you know what their preferences are and how you want to get your referrals from them and how they would like for you to do referrals. Please take the time to know your team. Because if you don't have an interpersonal relationship with your team, how are you going to get a warm handoff? How is someone going to come and say, hey, Chrissy, so-and-so is here crying and they really, really need you, if they don't believe in the work you're doing, or if they don't believe that you can help? You really have to spend time doing that. And so ultimately also, if people don't have their basic needs met, they are not able to move further. I cannot believe how often I reference Maslow's hierarchy of needs. I could have never imagined at the time I learned about it how actually important it would be in my professional life going forward. If people don't have their most basic needs met, if they don't have a place to live, if they don't have food, they're not coming back for chemo. If they don't have a ride, they're not coming back for chemo. So while you're all collecting really good data, I'm on the front lines making sure that they're getting from point A to point B. And I'm really excited about the opportunity to collect some of that information and maybe push that forward. But please don't forget that when you start somewhere, you've got to start down at the bottom. So let me back up also and mention that I don't really get to see all the new patients anymore. The reason is I've got such good buy-in that I'm taking care of all of the folks who are living in these two bottom levels of needs, all of them. The folks who have great support systems, the folks who have people bringing them to treatment, I say hello to them in passing and we know each other's names. I work in a really small clinic with 3 physicians, but they don't need me. Gratefully, you know lots of these folks. They've got resilience coming up out of their toes from some reason. They don't need me. They're doing fine. The people who need me are the folks who don't know where to reach down to get the resilience. They have no bootstraps. They're really, really struggling to get through, and now they have cancer. So I think buy-in. And when I spoke with my administrators impressively, they said, please make sure you mention that. I can't believe how many people don't realize how much buy-in you really need. I said, yeah, okay, I'm good, because I know how important that is. I've spent my 6 years at Geisinger gaining these relationships with primary care, with specialty care, so that I can call someone up in the office and say, Mr. Smith needs an appointment and I need it now. We've been waiting a really long time, and they do it because I've got that relationship. My patients don't need to make those relationships. I need to make those relationships, and it works for me. We've got really warm, easy handoffs. It's very helpful. So ultimately, if you are unsure of the needs in your community, we heard it yesterday, take a look at your community needs assessment. It will tell you what the problems are. It will definitely tell you what the problems are. And also, more importantly, when you are looking at hiring someone to do this kind of work, they need a certain amount of internal motivation that gets them through this. Ask them what it is, why this, what are you interested in? Why do you care about doing this? And make sure they know about the resources in the community. If they are new to town, it's very hard to refer people out to places. If they don't know, ask them if they know how to find a mental health referral. Do they know where to send someone who is having a psychiatric emergency? Do they know the crisis line number if someone is having a suicidal thought? I cannot state enough, I heard yesterday about supervision is absolutely imperative for ongoing ability. Taking care of yourself is wildly important. Feeling satisfied with the work that you're doing and feeling satisfied with the people that you're doing that work with also matters greatly. How you feel about the work you do shows through with your patients. It's really clear. People know when you're honest. People know when you're sincere about the work you're doing. And moving forward, I'm really just looking forward to just collecting some information, growing these programs, perhaps even, standardizing some things, which is something I hadn't really thought of before. I sort of consider myself the de facto leader of the Navigators because I've been around long enough. There really isn't anyone who's been around too much longer than me. And I'm always glad to talk to people about these things and get ideas about what we can do to make change. So I'm looking forward to what's coming forward. I do want to make some really brief statements on some of our pain points. We are still struggling with survivorship. Y'all, if you guys are struggling, please know we are too. We're having a really hard time getting there. I think that has an awful lot to do with provider buy-in. I'm working on that. It'll take a while. Distress screenings are also something I find interesting, and the reason being that if you give someone a thermometer and they pick an 8 and you don't ask them why they're an 8, and it turns out it's because they had to pee all day before they came to see you and they didn't get to the bathroom, they don't need a social worker, they need a bathroom. So you need to make sure you're asking these questions. Don't just ask them, are you distressed? What's going on? You're feeling distressed today. I'm really glad to meet your patients, but I am putting out fires, man. If your patient needs a shorter walk from the car to the office, let's get them a wheelchair. They don't need a social worker. And there are just not enough support services right now, right? So that's what I'm really hoping. So right now, I really am putting out the fires. I'm looking forward to creating better opportunities moving forward. And I would be remiss as a social worker if I didn't tell you about my two big soapboxes, which are we're just doing a really crappy job with advanced directives, and we need to do better. When I have the opportunity, I talk about it, but I really need that provider buy-in too, including with hospice referrals and palliative medicine referrals. I don't think we're doing a good enough job about that. And professional boundaries is of utmost importance. When you are hiring lay people, their training, their understanding of how far they can go, not being Facebook friends with their patients, not going to the birthday parties at home. It's a challenge, I know, because a lot of those folks are working within their communities, but it's really, really important for their ongoing sustainability and their ability to do their jobs well as well. So here I am. Thank you so very much for involving me in this. I really appreciate it. I look forward to questions.